And our final speaker this morning is Jenny Myers, who's from Manchester, works at St Mary's Hospital, which is where I was born a couple of years ago. I think it's a different hospital now, I think it was then. She's a senior lecturer over there in Manchester and is chair of the North West Preeclamptic Guideline Group. Is that about right? There we go. Jenny.
Thank you. Okay, so I feel like I need to sing, don't I? Yeah. I won't sing. Okay, so the boring bit now. I'm just going to give you a kind of little update, I guess. You're all very familiar with preeclampsia, I know, and the management of severe preeclampsia, so forgive me if I'm telling you things that you already know well, but I actually make no apologies for reminding you of the importance of some of the things I'm going to say. I'm just going to scoot through some of the issues related to the management of severe preeclampsia, and also just finish with some new evidence which is gathering around some new diagnostic tests for preeclampsia, which I think will alter the way we manage the disease in the future. We've heard a little bit about maternal death already. Every talk I give related to hypertension, I have this slide because I think it's a very sobering statistic, and clearly in the UK we're very, very lucky that pregnant women don't die very often at all in our care. But they are still dying, and when they die of preventable deaths, it's very devastating for us all. I've been very lucky to work in Bangladesh on a couple of occasions. This is their obstetric HDU. I don't know how similar it looks to your obstetric HDUs, but that's where all these ladies, all those three ladies you can see there, have all got quite severe HELLP syndrome and are being monitored pretty closely with some pretty basic equipment. But it's a really eye-opening for me to see what you can do with actually very little if you're very careful about the way you monitor and support these women. Anne-Marie's already given you some of these statistics and you'll probably already be very familiar with them. I haven't updated from the new maternal mortality report because we did better in the last maternal mortality report, and that doesn't mean the message has gone away. It just means that we need to remember the importance of that message. As Anne-Marie's already told you, deficiencies in care in many of the deaths related to preeclampsia, several deaths at term, and I think we all must remember the importance of term preeclampsia. That's a much more common disease, and around the world women are dying of term preeclampsia 3 times as often as they're dying of preterm preeclampsia, so it's very important that we remember that and don't ignore term preeclampsia. And this issue around the use of symptometrin comes up in every maternal mortality report, and it's very important to keep reminding ourselves of that, about not using symptometrin inappropriately. Specific recommendations that came from that report included interdisciplinary working, which is self-explanatory, but also this management of severe hypertension, and the threshold has been coming down over the last decade, and the importance of treating systolic hypertension over and above 150, and I'll show you some evidence related to that later. Early engagement of intensive care or high dependency work, and clearly early involvement of our anaesthetic colleagues is clearly crucial. Okay, now you probably all know how we define preeclampsia. I was at the International Society of Hypertension in Pregnancy meeting in New Orleans last year, and we spent, I kid you not, 6 hours arguing about the definition of preeclampsia. So whilst, 6 hours of my life I'm never going to get back, but while we know how to define preeclampsia, I think we have to accept it is a syndrome, and it is very, very poorly defined. And I get phone calls in my hospital every week, can you come and see this lady, we don't know if she's got preeclampsia or not, and I say I'll toss a coin on the way down, and then I'll give you an answer when I get there, because we really, we think we can tell. I spend a lot of time thinking I can tell and pretending I know, but actually it's a complex syndrome, and we don't always know what's going on, and often it's 6 months after the pregnancy when we find out actually she's got lupus nephritis. And that's actually what was causing the syndrome in pregnancy. So it's worth remembering that it is a complex syndrome. Now clearly you need to have new hypertension, which is difficult because lots of women have already got hypertension, but if you've got new hypertension, that's pretty straightforward, and you need to have proteinuria. I won't bore you with my getting on my soapbox about proteinuria, but if you will please remind your obstetric colleagues that once you have diagnosed proteinuria, which you can put your threshold wherever you want, the NICE guidelines put it on a PCR of 30 or 2 pluses on a dipstick, Once you have made that diagnosis of proteinuria, they've got proteinuria. It doesn't matter whether they've got 10 grams, 2 grams, whether their PCR is 35 or 3060. They've got proteinuria. What that tells you is they've got hypertension with some other endothelial involvements. Preeclampsia is an endothelial disease, it's a disease of the vasculature, and the most commonly affected vasculature is in the kidney. When the kidney becomes leaky, you get proteinuria above and beyond the threshold, which is normal in pregnancy. Once you've got that proteinuria, don't get me wrong, it's a completely hopeless sign, and it's very difficult to measure. There's all sorts of problems with it. But once you've got proteinuria, you've got proteinuria. So we don't want to be repeating PCRs, we don't want to be delivering people because their PCR's suddenly gone up. It will go up and down on an hour-by-hour basis. Once they've got proteinuria, somebody writes in the notes they've got proteinuria with hypertension. Wouldn't it be amazing if someone actually wrote in the notes, diagnosis preeclampsia? Be incredible. These are the other biochemical and hematological features that you're familiar with. Obstetricians are still obsessed with measuring urates. What I say to people is you can measure urates if you want, but they're of absolutely no value. They're not diagnostic and they've got no predictive ability at all. These are the 3 numbers that I want to know about when someone's talking to me about a woman with preeclampsia. I want to know if she's got thrombocytopenia, I want to know if she's got renal involvement, and I want to know if she's got liver involvement. You can tell me a bilirubin as well if you like, but it's almost always normal. You will know from managing these women on the delivery suite that most of the women that we look after, 95% certainly in our hospital, of the women that we look after with very severe preeclampsia on the protocols will have completely normal blood indices. So none of these tests are in any way diagnostic of the condition. All they tell you is that this woman has got multi-organ disease on top of her preeclampsia syndrome. They don't tell you anything else. They are features of severe disease, but they are not diagnostic. And we should never ignore people. In this business, when ladies come in and they've got a headache and somebody does some preeclampsia bloods and they say, oh, the PAT bloods are normal, we sent them home. You know, they're not diagnostic of anything other than multi-system disease and severe preeclampsia. And most of the women who fit, particularly, will have completely normal blood tests. You all know about the symptoms, which are suggestive of end-organ disease. They're actually very, very rare, those symptoms. Lots of women have headaches, lots of women have gastric pain, obviously, and I'm not suggesting for a moment that we should ignore those symptoms, but actually symptoms which are truly representative of end-organ disease are very rare in a UK setting. Fetal growth restriction, unfortunately, is very commonly associated with preeclampsia. I'm not going to go into detail about growth restriction today, but certainly new hypertension in the presence of a growth-restricted baby, or proteinuria, even more importantly, in the presence of a growth-restricted baby, is part of the preeclampsia syndrome. And the new American guidelines for preeclampsia talk about with and without severe features, which I think is kind of quite a nice way of thinking about it. So you need to have some diagnostic signs, and the most common diagnostic signs are hypertension and new proteinuria, and some of these other things are suggestive of severe disease. Clearly gestation at onset comes into that as well. You all know about the severe morbidity and mortality that we're worried about. Stroke is the thing that we're particularly worried about, which causes death, and the most important thing about stroke is that it's generally speaking a preventable death, and that's why I spend a lot of time jumping up and down about it on the labour ward. Perinatal morbidity and mortality, unfortunately most of that is not preventable, and we cause a lot of that morbidity by delivering women early, and there is a huge burden in terms of perinatal loss associated with preeclampsia in the developed world. Clearly early recognition of the disease is important, echoing some of the comments we've already heard, and we all, I'm sure, are very familiar with the management pathways that have been developed, the early severe preeclampsia protocols originating in Yorkshire and are now being followed across the country. So this is what the front page of our guidelines looks like, and it looks very much the same as your regional guidelines and the regional and the national guidelines in NICE, and I'm not going to bore you with those, you all know the details of those. In terms of general principles when we're thinking about preeclampsia, I say this to the juniors on the labour ward and on the antenatal wards all the time, what is it you're worried about? So you've got a bunch of numbers in front of you, you've got a woman in the bed who looks pretty well, you've got a baby on the CTG that looks okay, and yet you're jumping up and down telling me this lady's got to come to labour ward. What is it that's bothering you? And so we really got to think about that. And I know that sounds a bit oversimplistic, but often I think that gets a bit lost. This woman's got preeclampsia, we've got to do something about it. Well, actually, what we don't need to necessarily do anything about it at the minute. What we need to do is talk to the woman, explain the unpredictable nature of her condition, the need for close surveillance, and we're going to work out what the risks are and what the risk benefits are of delivery. And that will be different for every single woman. And these are the general guidelines which are put in the NICE guidelines, that around less than 34 weeks you want to try and continue the pregnancy as long as you consider it safe to do so. How long's a piece of string? Between 34 and 37 weeks we really don't know what to do, so that's good. So we're doing a trial at the moment. I don't know if any of you are participating in the Phoenix study, but we're randomising women at St Mary's and several countries around, several hospitals around the country in terms of expectant management versus immediate delivery for women between 34 and 37 weeks. And after 37 weeks, delivery, generally speaking, should be offered. And that's not to say that all women want to be delivered after 37 weeks, but clearly the benefits of continuing the pregnancy are a lot less, and so we feel more comfortable about delivering them at that stage. I don't know if any of you have seen the Peers website or any of the Peers publications. There's a very interesting article, which is a few years old now, in The Lancet by Peter von Dadelson and his group, where they put together a whole series of observations on women with preeclampsia and severe preeclampsia and tried to come up with a prediction model to predict those women at risk of the worst outcomes. And this was developed in Canada, but also in using data from India and several other countries. There are lots of problems with this data, but it's the best we've got really in terms of identifying which women are most likely to run into problems. And I use this quite often just out of interest. I try and guess the number just to demonstrate to myself how little I know of how high I think the number's going to appear in the box. I'll show you it in a second. And it always surprises me, the answer that we get. So what you do is you look at those features, which you'll all be assessing on any woman that's on your labour ward with preeclampsia, and you try to make a decision about whether you're going to deliver this woman or not. So here's a woman from Friday who I was called down to see on our labour ward. And the first thing I want to just say about this lady is to just echo our previous speakers. This lady had been, and I'm ashamed to say, this lady had been on our labour ward for 36 hours when I was called to see her. Very nice of them to call me to see her, that was good. But no one in that 36 hours had used the word preeclampsia. Isn't that amazing? She'd been seen by 4 consultant obstetricians and 3 consultant anaesthetists. And nobody had used the word preeclampsia. And everyone was running around because her blood tests were really abnormal, and oh my God, she's really unwell, and what are we going to do with her? And she's refusing delivery. She won't be delivered. And this is what the consultant obstetrician said when she rang me. She won't be delivered, Jenny, what are we going to do? I said, well, let's think about it. Why do we want to deliver her? She's 32 weeks, why doesn't she want to be delivered? She's really worried about a baby going to the neonatal unit, and I've told her that a baby's going to be fine. Okay, well, that's good then. So if you told her a baby's going to be fine, so we've got it. I mean, I know I'm taking the mick a bit, and Shahar won't mind me saying this, but, you know, you've got to think, like, we're worried, but we've got to think about what the women are worried about. And we've already heard some of those concerns. So, who is brave enough to guess what they think the risk of severe adverse maternal outcomes is for this woman who's got a blood pressure of about 150 over 100 at this point with on medication? Blood pressure is never in the mix in terms of predicting outcomes because obviously we play with it. She hasn't got any chest pain or breathlessness, her sats are normal. She's got platelets of 118, you'll be interested to know her booking platelets were 260. And she's got creatinine of 132, and her creatinine a month ago was 68. And she's got an ALT of 22. Anyone want to guess? Do we think her risk of a severe maternal outcome is 1%, 10%, 50%?
That's high.
Pardon? So stroke, eclampsia, acute renal injury, hepatic rupture, going to ITU, that kind of business.
10%.
I've got some 10s. Got some 1s, got some 50s. Good! Okay, I think that demonstrates quite clearly that none of us have got any idea. So I guessed, when I put these numbers in, I always guess, and I guessed 5%. And I was wrong. It was 2.5%. And that is done from the upper end of the, so it gives you the highest risk from the risk prediction model, if you like. So the risk is somewhere lower than that, probably. Are we surprised by that a little bit? Some of you who said 1%, not so much. So I think I'm not saying that this is the most robust information in the world. I'm not saying that you should all be hotting onto this and making clinical decisions based on this now, but it does give you an idea of what we're worried about. And so when I said this to the consultant on the unit, I said, well, you know, we've got to give this woman some realistic risks of the risk of her baby going to the neonatal unit and the risks of prolonging her pregnancy, having to stay in hospital, and all the stuff that's going to go around that. And there's no right or wrong. 32 weeks, perfectly reasonable to deliver this woman, absolutely appropriate. But if she doesn't want to be delivered, and we've had an informed discussion with her and have explained what's ahead, she might have a stroke, hopefully she won't have a stroke, she's on labour ward, but she might fit, certainly. She might end up with some renal loss, then, you've got to explain all of those things to her, and she needs to try and make a decision.
Surely it's not a static picture, is it? You have to look at that as a
Absolutely. That's not a static picture at all, no. And you've got to be reassessing, and that's what we're doing, isn't it, with that continual surveillance. And I put some slightly arbitrary limits in the notes when I agreed a plan with her, which looked a bit like, if your creatinine doubles over the next 48 hours, your renal function, let's be sensible, is probably deteriorating, so we ought to deliver you. If your platelets are less than 100, we should think about delivering you. The risk profile will change. So absolutely, you need to be reassessing it all the time. And I think you need to give the team and the women some limits, hopefully, about where you're going to go with that decision making. Make a plan. Make a plan. Make the obstetricians make a plan. We're so bad at it. Okay, you all know about stroke. I'm hoping you all know about this data, which is the only data we've got really on stroke, apart from the observations made in the maternal mortality reports, that the strongest association with intracerebral hemorrhage is systolic blood pressure. So the days have gone where it's okay for the midwives to only tell you what the diastolic blood pressure is. Systolic blood pressure is the number that you want to know. Systolic blood pressure is the number that you want to get down to around 150, hoping that you don't plummet the diastolic blood pressure too much. So the vast majority of women who had a hemorrhage in this series, lots of problems, retrospective case series, but nonetheless the best evidence we've got, treatment of severe systolic hypertension is what we should be doing. And again, you'll all have your ways of treating systolic hypertension. The message from the maternal mortality reports and the message I try and teach the juniors and the midwives on our labour ward is not about what agent you use, because let's face it, they're all pretty much of a muchness. It's about effective treatment. So if your first agent doesn't work, don't just keep giving it. So if you've given 2 doses of oral labetalol and the blood pressure's not shifted at all, you really want to give some IV labetalol. Well, you can give a bolus of IV labetalol, but if that doesn't work, you've really got to shelve your labetalol and go to something else. The other thing is to try and give blood pressure medication, but give it time to work, and there's a fine balance between giving it time to work and ignoring whether it's worked or not. So you need to be going every half an hour, every hour to see if the blood pressure medication's been effective. And you're aiming to get that systolic blood pressure down to within safe limits, by which I mean less than 160 within half an hour ideally. And if by 2 hours you're not there, you need to be thinking about giving some other drugs. Clearly you need to be cautious. Some of these women have got profound hemodynamic disturbances, and you give them a bunch of medications at once and they feel terrible, particularly if you give them magnesium sulfate and nifedipine at the same time. They feel very, very unwell, which is very unsettling for all concerned. Very little evidence. This is a systematic review that was in BJOG last year, if you're interested, around comparisons of antihypertensive medications. To be honest, they're all pretty much of a muchness. Nifedipine and hydralazine are by far the most effective antihypertensives, and nifedipine is probably not as bad as we thought in terms of causing bad hypotension in the mother and affecting the baby, as long as you give it appropriately and you don't give it sublingually. Target blood pressure achieved less at the time with labetalol or methaldopa, which is probably what you all would have said. And again, I'm just going to scoot through this because I know you all know it, but again, just important to remind us all about the importance of fluid balance. No deaths associated with pulmonary edema in the last, I think it's the last decade now, because we're all managing fluid very carefully. We all know about running these women dry, not giving fluid challenges in the absence of blood loss, and if you have got bleeding and blood loss, you need to replace that with blood, not with crystalloid, ideally. This is my little cartoon. When you've got a healthy, normal vasculature with a nice, healthy cuboidal endothelial surface with all tight junctions nicely fitting there, you put fluid in, the vessel behaves appropriately, will dilate, you perfuse your kidneys, you pee it out, you don't congest your lungs, and you don't get vasoconstriction. When you've got preeclampsia, you've got an endothelium which looks like that, and if you look at vessels under the microscope, which I spent many years, which I also won't get back doing, that's what they look like. They're gappy, essentially, and basically you put fluid in and you get vasoconstriction, really importantly. The fluid leaks straight out through those vessels, and you get all the signs which you're familiar with. You don't improve renal perfusion at all. You probably make it worse, and so you don't improve urine output, and so you give more fluid, and that's why we ran into problems in years gone by. It's just if you just look at the numbers at the bottom there, 100 deaths from pulmonary edema. Now, there is a potential that we are causing harm by running these women dry, which is always the way with medicine, isn't it? You get one thing right, something else goes wrong. So if you run these women very dry, there is some epidemiological data from Canada now to suggest that acute renal failure, obstetric acute renal failure, is on the increase. And there is a hypothesis that's related to the fact that we're running these women very dry. So you kind of win with one hand, you lose with the other. I think the important message from this, and the important message that they make in the paper, is that whilst the frequency of obstetric acute renal failure is going up, women don't tend to die of acute renal failure, and it's with supportive methods and hemofiltration they get better. So whilst we don't want to put a load of women on ITU needing hemofiltration by any means, I think we also don't want them dying of pulmonary edema. So we do need to just be a little bit careful, but I'm sure you will be extremely careful anyway. 5 minutes, oh my word. Right, so I'm going to tell you about PLGF very, very quickly in 5 minutes. So diagnostic uncertainty, I talked before about this issue of this being a syndrome that's hard to define. People like me spend every day all week scratching our heads about what preeclampsia is, what are the different phenotypes, how can we understand it better, and when should we deliver women with preeclampsia is clearly the kind of million-dollar question. Blood pressure does this in preeclampsia. If you didn't get the message about proteinuria before because you were asleep, shame on you. Proteinuria is a qualitative sign, okay? I hope you've all remembered that. I won't bore you with this, but suffice to say that these signs at the bottom here, hypertension, proteinuria, inappropriate clotting, liver, renal dysfunction, are all very end-stage signs of vascular endothelial disease. And upstream of that, causing most of preeclampsia, not all, but most preeclampsia, is this placental damage that happens in early pregnancy. We've now got the ability to measure this guy, which is placental growth factor, PLGF, which is indicative of placental disease. It's a bit like a placental function test. So you add it into the soup, you're measuring function tests of all the other organs, and you can also now biochemically measure the function of the placenta. It's much lower in pregnancies affected by preeclampsia. You can do it on this benchtop kit. We did a study, and I'm just going to race through this to tell you that. In terms of predicting women who require delivery within 2 weeks, PLGF essentially is very helpful. So we did a blinded study, 287 women who presented to a day unit or to an antenatal ward with hypertension before 35 weeks. And in terms of predicting which women were ultimately going to end up being delivered, and this is in 7 different hospitals in the UK, so very varying practice, PLGF was very helpful. More importantly, probably, in this group of women, PLGF is very helpful in telling you they haven't got placental disease. So when the PLGF is normal, it helps you to say this woman hasn't got RIP or placental disease. That's not to say she hasn't got some maternal disease going on, but she's probably not going to develop the severe consequences associated with preeclampsia. Much better than any of the other tests that we do, but you knew they were crap anyway. And a very low PLGF. You can see there on that Kaplan-Meier, the women, and this is blinded, remember, all blinded data, their pregnancies lasted were much shorter in duration following their PLGF test. So at St Mary's over the last year, we've been doing a clinical evaluation. Most of my time is spent looking after women with hypertension and diabetes in pregnancy. And they're a very difficult group of women to diagnose preeclampsia in, clearly, because most of them have got hypertension, many of them are already proteinuric. Very difficult when things get worse from a maternal perspective and they're on the labour ward needing IV hydrolysine to know whether that's maternal disease and poor response to pregnancy, or whether they've got preeclampsia, and what does that mean in that context. I spend a lot of time scratching my head about that. And PLGF is really helpful. Here's just 3 very straightforward cases, really. 2 women with diabetic nephropathy, both of whom are hypertensive and proteinuric. One's got a very low PLGF, and all the hallmark signs of placental failure, but much more confidence delivering her earlier. On the other hand, on the right-hand side there, a lady with very bad kidney disease and diabetic nephropathy and bad hypertension, needing her antihypertensives to be hiked up quite aggressively, but a kind of pretty healthy placenta. So that means I need to monitor her very carefully. I need to treat hypertension, but I don't need to deliver her preterm. So you can see in this group of women, it can be very helpful. Okay, so just to recap on the main messages, maternal morbidity is rare in our settings, but it's also very difficult to predict. But in general, it's preventable, and the most significant cause of maternal morbidity related to stroke is preventable by good management of hypertension. And that means keeping your eye on the ball and making sure the antihypertensives that you're giving are actually working. It's frequently a complex and atypical picture. No two women with preeclampsia look the same. We may have some new tests which will help us to pick out which women have got placental disease and placental failure, but that's not to say for a moment that women with term preeclampsia, who I'm not sorry to say, but this test that I just told you about is great. It will not help us in term preeclampsia because the majority of those women have a reasonably healthy placenta. And so we still need to do a lot of work in identifying those women at term who are going to worry us on the labour ward. And I've not talked too much about the baby today, but as you all know, perinatal loss is still a huge issue. And in the women I look after, I lose at the moment about a baby a month, roughly speaking, because I referrals in with preterm preeclampsia from across the region. And so perinatal loss is a big, big issue still, and there's a lot of work to be done around that. Thank you very much.
Thanks a lot. Lots of interesting things to think about for all of us. But any questions before we all go to lunch?
Can I just ask a question? You've alluded to the Yorkshire guidelines, you've got the Stepping Hill guidelines. Why have we got regional guidelines rather than national guidelines?
Why have we not got national guidelines?
Yeah, why?
We have got
but why is Manchester different from Leeds?
Well, I think if we were to look at the nitty-gritty, I've got the Yorkshire guidelines, so and I compare and contrast a lot, and Derek and I speak about them, so that, you know, the guidelines look pretty much the same. I think the only differences on our guidelines are there's some phone numbers, there's some specific details which are logistics and practicalities related to where women should go, who should be called, all that kind of thing. So I think the actual nitty-gritty of how we manage hypertension and fluid balance and the important aspects, I think, I would like to think, I don't know if people have got comments, are reasonably consistent across the region. I don't know if that's, you wouldn't agree?
Well, across medicine we seem to have lots of local guidelines that I think should be replaced more nationally.
Yeah.
Jenny?
What's the best gestation to measure the PLGF?
Good question. So it's only really useful before in women who present before 35 weeks, might have some use up to 36, 37 weeks. So we're about to start a trial to look at the use of PLGF, either revealing the results or blinding the results in women presenting very similar populations, so women presenting to day units, community midwives and so on with hypertension, to see whether it changes ongoing management. And it's under review at the NICE Technology Assessments Panel at the moment, as well as a new diagnostic test. So it's not quite, it is available, you can get hold of it as got a licence, but I think we're not sure yet across everybody, everyone presenting with hypertension at less than 35 weeks, what exactly its role is going to be yet. But I think over the next few years we will be rolling it out. Where it really does have a help, where it really helps me is in, and it's smaller, much smaller numbers of women, but a lot of morbidity amongst those women is the women who've already hypertensive and already proteinuric, where you just don't have any diagnostic symptoms to go at really. And is the fact that you've doubled down on fedipine in the last 24 hours mean they've got fulminating preeclampsia or not? They're the women where for me it's most helpful, but obviously they're much smaller number of women.
Any other questions? Sounds great.
Thank you.